Welcome everyone. My topic is rational pharmacotherapy and the pharmacist's approach toward evidence-based recommendations. It's not a surprise I'm a pharmacist, and my vision is to have educated patients in the world. And therefore my mission is to be a core character in internationally recognized patient education programs. For this, I want to show two opposing projects. The first is about an add-on question, and the second is about how to avoid something. My first project, therefore, is about nabiximols and whether we should add them to multiple sclerosis-associated spasticities treatment. It is a fact that it's about 2.8 million people who have multiple sclerosis. And from them, about 28% have spasticity, which inadequately responds to the standard medications like baclofen or tizanidine. And also, here comes nabiximols, which is a new agent in this area. And the clinical question, therefore, is, does nabiximols improve the symptom of multiple sclerosis-associated spasticity? We wanted to find the answer by this meta-analysis and started the selection from about 3,000 articles, and with an agreement higher than 90% and Cohen kappa greater than 0.8, we achieved 14 articles to be retractable and use them. From them, 5 was eligible for our primary outcome. It was the treatment responders by definition in the study in spasticity numerical rating scale. This spasticity NRS is a self-reported parameter. It starts from 0, no spasticity, to 10, worst spasticity ever. The responder rate is generally 30%, but as the accepted indication also mentions, after 4-week treatment, if we see a 20% decreasement in this NRS, it is feasible to have a 30% decreasement in the further period, as well as the treatment itself is also feasible. But we have to concentrate on the fact that while the study populations were fairly similar, the study designs were highly differed. Just for an example, here this last one is a two-way enrichment study design where they excluded those patients who are essentially non-responders. Because, for example, they have too long period no good treatment of their spasticity. But let's concentrate on the effects. And here you can see heterogeneity, which seems lower than 70%, but technically we should not accept low heterogeneity in my studies because of the low number of used studies. Also, I want to highlight that we have an odds ratio of 2.42. And it was statistically significant as well. It could mean that at least 2 times more people respond well to nabiximols than to placebo. Technically, we should concentrate on the way of effects because of the differing study designs and the heterogeneity. And we should only say that nabiximols truly have effect on spasticity. On the other hand, we have 7 further secondary outcomes. From them, I want to highlight the subject's global impression of change, which is a global parameter, therefore contains such things that side effects, for example. And if you see the data and retracted articles, the population is, and the study material has fairly same features like before, and also the odds ratio is pretty similar. It's about 1.83, and the effect, it says, statistically significant. So it also underlines that nabiximols has good effect in the spasticity of multiple sclerosis. So after this, we should summarize that nabiximols that we highlighted, we proven the efficacy of nabiximols based on randomized and blinded clinical trials. But we have several limitations, not to mention this differing study design. So the conclusion is that nabiximols can be alleviated by spasticity can be alleviated by nabiximols, and this can be used in symptomatic treatment. So the clinical implication is that we can use nabiximols as an add-on agent in symptomatic treatment. But we need stratification, what population, which time frame, what severity it should be used, and comparisons, for example, with baclofen, the already used agents. My second topic is about patient education of lactating women in the internet, which is about the question whether how we can avoid some kind of agents. Because medicines might pose danger to the baby or decrease breast milk. It's not nice. But the undue rejection of medicines is also disadvantageous. And here comes the over-the-counter drugs, especially if they sold on the internet. And in this case, where is the medical supervision? But internet itself is a great source of information. But is this information proper? And if this proper information is good, is it enough efficient? So I think this is the first question what we should answer before we make a good information source. What is the most effective way to educate lactating women on the use of OTC drugs? Therefore, we want to compare the interventions, and after our trial, we could have a way how to make an education to achieve rational and safe use of OTC drugs. Our eligibility criteria is lactating adult women, and here you can see the interventions, and the outcome would be the knowledge translation. Now we are in the state of preparing for a pilot study, and here you can see that we have a draft material which has topics like general approach of medication, safe and unsafe over-the-counter agents, and management of common painful situations. And for the summary, I want to highlight again that rational pharmacotherapy needs evidences. That is what I want to find, and I hope you also want to find. And for the end of my presentation, I want to highlight a quote from Senor Diabens. Science is based on the experience that nature answers intelligent questions intelligently. So if she is silent, there may be something wrong about the question. Thank you.
So, Dénes, it's always a pleasure to listen to you. If I may, I want to ask two questions from both of your studies. The first one, can you go to the cutoff for responders?
Here.
Yeah. Can you clarify that? What do you mean by this? This is a percentage value, right?
Yes.
This is about how many from the population have responded to the treatment, or can you clarify this?
Yes. So, patient has some kind of spasticity. It could be about, for example, 8. It's a severe spasticity. And if we see about 30% decreasement, I'm sadly not, okay, let's say 10 is this kind of spasticity, worst spasticity ever. So if we see 30% decreasement, namely it goes down 3, it is the cutoff point that we achieved now, and the spasticity, and the patient has that kind of spasticity which is responded to the nabiximol treatment. Is it a bit clearer now?
So basically, in the first study, for example, this means that even with placebo, 42 patients have achieved at least 30% improvement in their symptoms?
Yes.
Okay. Okay.
We had several meetings about these kind of questions. Multiple sclerosis patients can have a really good placebo effect. Technically, this is really important. Am I right?
Right, this is very important to clarify. And my second question is about your second study. So you're designing 4 different interventions.
Yes.
But, you know, for example, an aspirin is an aspirin. It's always an aspirin, and it works in the same way. But when it comes to these interventions, there is a performance aspect. Somebody is actually, these are all creative efforts, and somebody is going to perform these. And there might be differences between different performers. How do you hope to achieve a comparable level of performance or a comparable grade of performance between the interventions? Just if I may, for example, if the same person is designing all of these and performing all of these interventions, this performer might be more comfortable doing a podcast, but maybe his written language is not as competent. How do you hope to standardize this?
Actually, we are working with a group of Szeged's informatics, and therefore we have a group to achieve the higher level in every kind of interventions. So, yes, it is a bias factor. We know that it is a bias factor. That's why we try to make it as homogeneous as we can. That's why we make every kind of material by ourselves and use specialists of the field, like video content field itself. Okay, so this is how we want to achieve homogeneity in the size of the technical background.
Thank you. Congratulations, fantastic topics that you have here. Actually, regarding your meta-analysis for the implication for practice. You are saying in the research that you need to clarify when to use it, what population, but actually I think that you kind of introduced in your background that in some patients, some patients are non-responders for the other treatments. I think you should probably add to your conclusion or implication for practice that, for example, you can use the medication in the non-responders. I mean, you see the difference, I mean, when to give them.
Mm-hmm. I understand this. Yes, thank you for the quote. It's a remark, am I right?